شكرا. Thank you, Mr. Chairman. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. My objective is to review some of the needed equipment in the ultrasound used in scrotal imaging, and review various types of testicular masses, and review the ultrasound of these findings of the testicular masses. Regarding to the equipment of the ultrasound, we need to prepare the room, and should be warm to avoid the cremastic reflex, especially in children, and to warm the gel. And the scrotal ultrasound is performed in the patient lying supine position with supported testicles by a towel in the upper thigh, and the second towel will to hold the penis. And we should use high frequency probe between 7 to 15 megahertz, and the ultrasound equipment should have the Doppler capabilities, and it is essential, and we should just optimize the wall filter, lowest scale, high possibility of power output, and obtaining the proper gain. And we start with the normal ultrasound of the testis, and we should take comparison view for the other testis in the real time and the color Doppler, and we should not change the parameter, and we should take long axis, short axis, with and without measurement. When we do the ultrasound of the testicle, we have what we call no-touch testicular lesion, and these are simulating some pathology. We should be aware of these lesions, and I will discuss some of these lesions. Prominent septation, as we know, the testicle is divided into lobules separated by septi, and these septi sometimes give us false impression if we use high frequency ultrasound probe. For example, we should use the high frequency probe, but if we use 5 megahertz probe, we have looks like a hypoechoic mass in that area compared to the normal testis. This is due to sound hitting the septation, reflecting away of the testis, and giving the pseudo looks like a pseudo mass. If we change the probe from 5 to 7 or 8 or 10, and change the examination from the anterior to posterior, we don't see this mass. So prominent septation sometimes give you a false impression that you have a pseudo mass in the testis. Also, mediastinum of the testis can also sometimes give a false impression. The mediastinum of the testis, it is a fibrofatty tissue causing the direction of the long axis of the testis, and contain vessels, seminiferous ducts, and sometimes it will give some shadowing. Here in another patient, there is a shadowing we scan from the anterior approach, and we have shadowing from the mediastinum, and when we repeat the scan from the posterior approach, it is also give the shadowing, and we see the mediastinum here. Keep it in mind, it is not a real lesion. Vascular channels also give sometimes looks like pseudo lesion. Classic appearance of the testicular artery here, it is circumferential around the testis, and you have the perforating vessels, and here this is the normal. Sometimes we see horizontal vessels in the mid of the testis, and it is a normal variant. Rete testis is another pseudo lesion. Rete testis is a coalescence of seminiferous ducts at the level of the mediastinum. This is the seminiferous ducts, this is the mediastinum, and these are coalescence of these ducts. Sometimes it is dilated, as we see here in this case, and it can be bilateral, can be symmetrical or asymmetrical, and usually it is not bulbable. Can be, this Rete testis can be due to obstruction at the level of the epididymis or at the level of the vas, and can be increased in patient with post-vasectomy, and it is associated with the epididymal cyst. Here it is a Rete testis, and with the cyst, another patient with the small ductectasia of the seminiferous ducts, with a small cyst in the epididymis, another patient with cyst in the testis, and this is a patient with Rete testis with multi-septated epididymal cyst. Calcification in the testis can be either in the tunica albuginea, can be in the scrotal nerves, and can be in the intratesticular. And in the tunica albuginea, as in this example, and in the intertesticular, it is likely, it is small, but it is more than larger, little bit larger than the microliths in the microlithasis of the testis. And but we should keep in mind, sometimes dermoid Berndt tumor have only calcified lesion. Keep it in mind not to miss as a normal calcification. Zebra or striated testis, it is due to prominent fibrous tissue in the testis due to atrophic changes, and can be seen in atherosclerotic patient, can be seen in the diabetic, can be seen after radiation. And this patient, you have multiple striated testis with the prominent fibrous tissue in that. Keep it in mind, it is not a lesion. Another patient with striated testis with large hydrocele. Testicular masses scrotal masses can be extratesticular, can be testicular in origin. Testicular in origin can be solid and can be cystic. I will try to come across some of these lesions. With the ultrasound, testicular masses can be solid or complex, can be bulbable. If it is solid and complex with bulbable mass and high probability of the malignancy will be for that mass. If that solid mass with complex, but no, it is not bulbable, and it is an intermediate probability of that mass. Simple cyst, if it is not bulbable, it is low probability of the tumor, malignant tumor, but we should follow this patient because some of them it will change to malignancy. Simple cyst, if it is bulbable, it is very low probability to have malignancy. Testicular pathology can be neoplastic, can be infarction, can be infective or traumatic in origin. Grace can be iso, hyper, or hypoechoic. Grayscale or real-time ultrasound, it is difficult to differentiate between the four classified masses. For example, in this patient, you have mass in the testis, and it is homogeneous, little bit homogeneous with some calcification, and this another mass with homogeneous mass, and this looks like cystic mass, and another mass. With the grayscale, we cannot differentiate what is this, what is this, what is this, and what is this. But if we add the history, and if we add the color Doppler, it will help us in the differentiation of these masses. For example, in the first one, there is an internal flow, increased flow of that mass, and it is malignant seminoma. And this mass, there is no flow with that. Patient with the acute pain, it is segmental infarction, and this mass you have see the anechoic area and surrounding by hyperechoic vascularity, and it is an abscess. And this mass, it is post-traumatic. You see the normal, this is disruption of the testis with normal vascularity in that area, and hematoma have no vascularity. Classification of testicular tumor, either primary or secondary. Primary can subdivide it into germ cell tumor, non-germ cell tumor. And the primary testicular tumor, 1 to 2% of male cancer, first one cancer, between 15 and 34 years old, bilateral, and it is 90% cure. A predisposing factor, some of the predisposing factor for the testicular tumor. Germ cell tumor can be subdivided into seminoma and non-seminomatous tumor. With the seminoma, it is about 50%, 30 to 50 years old, less aggressive, radiosensitive, and there is no tumor marker elevated, but sometimes about 2% it will be elevated, and increasing in the undescending testis. Non-seminomatous tumor, it is also approximately 50% and can be mixed or can be other types. And the tumor markers will be elevated, especially the alpha-fetoprotein and human chorionic gonadotropin. With therapy, these tumor factors should be returned to 0. Here is an example of a classic seminoma. Usually it is homogeneous mass with increased flow, but sometimes you have an exception, can be heterogeneous. You see here in the mid-ball of the testis, homogeneous mass, hypoechoic mass with increased vascularity. At histopathology, the mass, it is a classic seminoma. Another patient, 25 years old, with right testicular mass, also have the mass, it is a little bit homogeneous with increased flow and proved to be another classic seminoma. This patient, 33 years, with testicular mass on the left side, and the testis on the right side, scrotal circuit is not seen. We did the ultrasound of this patient. There is a mass involving the whole of the left testis with increased flow, and there is inguinal lymph node on the right side, and there is a large mass in the right mid-lower abdomen with calcification. We did for the patient CT scan, and the mass in the right mid-lower abdomen with calcification and lymph node in the retroperitoneal region, even in the mediastinal region, and the inguinal node. Biopsy of this mass, it is proved to be seminoma. After treatment, the mass is shrinking in size, and the nodes are almost disappear. But the patient, it is refused to do orchidectomy on the left side. And this patient had bilateral seminoma, one in undescending testis in the right side and the left side. Non-seminomatous tumor, it is common in 30 to 40 years of age, usually heterogeneous with cystic or calcified component. It is more aggressive than the seminomatous tumor, and 50 to 75% have metastasis, and it is less radiosensitive. This is this patient, 22 years old, with alpha-fetoprotein high. You see here a heterogeneous mass with increased flow, with disruption of the tunica albuginea, and the mass, it is infiltrating the epididymis. And at histopathology, it is germ cell tumor, non-seminomatous type, with teratoma 50%, embryonal 30%, yolk sac 30%, with seminoma 2%. Another patient with left testicular mass. Here you see a large mass with heterogeneous, with calcification. And the CT scan, you have multiple nodule metastasis in the lungs. And it is germ cell tumor. This patient, this is germ cell tumor with teratocarcinoma. This patient followed up after 3 years. He developed a large mass in the chest and large mass in the left inguinal region, and it is proved to be a sarcoma for metastatic teratocarcinoma at histopathology. Another patient, another example of left testicular mass in 31 years old. You have heterogeneous mass with increased flow, with cystic and solid component, and the mass, it is proved to be mixed germ cell tumor with a predominantly yolk sac type. questioning embryonal carcinoma. 20 years old patient with right testicular mass with heterogeneous mass, cystic component, increased flow. At histopathology, it is germ cell tumor, non-seminomatous type of choriocarcinoma. I move to the gonadal stromal tumor. We have the Leydig cell tumor, SERTOLI cell tumor. This patient have a 25 years old male, status post-right orchidectomy due to trauma, and he has complaining of acute testicular pain, sent for ultrasound to rule out epididymolysis or mistorsion or tumor. We did the ultrasound of this patient. We have the hypoechoic mass, well-defined mass with increased flow. After 3 weeks, they repeat the study. The mass, it is very vascular, well-defined hypoechoic mass. They did for him partial orchidectomy with and the mass proved to be SERTOLI cell tumor. SERTOLI cell tumor, it is a rare tumor. It is about 1% of testicular tumor. It is equal in all ages and result in feminizing hormone secreting estrogen and gonadotropins. And it is associated with some syndromes like Klinefelter, Carney, or Birch-Juger syndrome. By ultrasound, it is a small, well-defined, marginated hypoechoic mass, and if it is large, can be calcified with necrosis or hemorrhage. Another example, 53 years old, complaining of testicular swelling. It is dull pain, no urinary symptoms seen. You see here, there is an hypoechoic mass in the upper ball of the testis. With partial orchidectomy, the mass it is proved to be benign yolk cell tumor. This patient, 9 years old, with congenital adrenal hyperplasia, this case from Dr. Nujum, and the patient has bilateral infiltrative fibrosis involving both testes around the mediastinum, and the follow-up of this patient for 16 months after the first scan, the hypoinfiltrative fibrosis around the both mediastinum decrease in size, and follow-up 2 years, it is almost burned out of the tumor. And this patient with congenital hyperplasia, and giving the patient corticosteroid, and the diagnosis is hyperplastic adrenal cysts. This can be seen with high level of adrenocorticotropic hormone associated with Addison disease, Cushing syndrome, congenital adrenal hyperplasia, Nelson adrenogenital tumor. The treatment with these patients, it is corticosteroid, and these lesions represent hyperplasia of Leydig cell or adrenal cyst from the embryonic time, with the testis is located in the intraretroperitoneum. Histologically, differentiation from Leydig cell tumor, it is difficult. Failure to complete regression after steroid therapy does not necessarily prove to be a presence of the tumor, because it is important to know that 10% of these Leydig cell tumors are malignant. Some of the miscellaneous causes of the testicular masses. This patient is 25 years medically free, complaining of barely testicular mass in the right testicle for the last 9 months. And you see here large mass involving the half of the testis, and it is calcified and looks like hypoechoic, surrounded by hyperechoic. It looks like onion rings, and it is epidermoid cyst. Epidermoid cyst, it is a cystic cavity lined by stratified squamous epithelium, and this onion skin appearance is due to alternating layers of keratin and desquamated squamous cells. This patient, 40 years old, with acute testicular pain. You see hypoechoic mass wedge shape in the mid portion of the testis with lack of vascularity, and with at the histopathology it is segmental infarction. Another patient with segmental infarction, also you have hypoechoic mass with no vascularity. This patient, it is interesting, 29 years infertility, has bilateral testicular lesion, have alpha fetoprotein high. We suspected could be bilateral germ cell tumor. And you see here the grayscale scan, multiple lesions, hypoechoic lesions involving both testicles in the right and the left side. With the testicular biopsy, the histopathology came, it is SERTOLI cell-only syndrome with no evidence of active spermatogenia. What is SERTOLI cell-only syndrome? It is called also germ cell aplasia, described a condition in the testis which the SERTOLI cells are absent. The SERTOLI cells function has to stimulate the follicular stimulating hormone by the hypothalamus, which help in the promote spermatogenesis. With this patient, with this syndrome, it is usually between 20 and 40 years of age. Patient came with infertility and found to have azoospermic with no sperms in his ejaculation. Another example of testicular mass, this is the 38 years old with epididymal and testicular mass, 3 months, and he has history of TB. You see here, this is the left testicle with the grayscale, multiple hypoechoic area. It is not vascular. In biopsy of this mass, it is to prove to be granulomatous disease and diagnosed TB, and the patient is discharged from the hospital on anti-TB treatment. Before we finish, we have this patient. This is the patient with epididymitis with increased flow, also increased flow in the testis, and the left testis is swallowing, and this is a patient with epididymal orchitis. Another patient with heterogeneous mass, heterogeneous ecotexture of the testis with increased vascularity. With hydrocele, it is not complicated, non-complicated orchitis. And this is another patient with complicated orchitis with abscess formation. You have seen the skin thickened with hyperemic skin or scrotal skin and increased vascularity of the testis, and with anechoic area surrounding by hypervascularity with abscess. Another patient with
5 minutes, Dr. Hisham.
Almost finished. With another patient with increased vascularity with hypoechoic areas in the testis with abscess formation. In conclusion, high resolution real-time sonography has high degree of accuracy and sensitivity in the detection, characterization, localization of scrotal lesion, making undisputed modality for the choice of imaging of the scrotum, can differentiate different pathologies, tumor, non-tumor, TOSH acute cases, and involving the investigation of the infertility. And thank you.